had to turn the recording back on. So like I said, I'm thrilled to welcome you to this webinar and be joined by Sandra Clarkson and Dr. Monty Ghosh. The webinar is a fairly straightforward, process or a straightforward agenda. We're just doing a brief introduction right now, then I'll turn it over to Monty and Sandra for a presentation, then we'll be back with a question and answer period at the end. Just a little bit of housekeeping as we get started. Please use the question and answer tab. You see a little Q&A tab there on your control panel. Please send questions through the Q&A tab. You are more than welcome to use the chat function as well to share information with your peers or ask questions of your peers. I'm finding in our other webinars, it's a really good way of sharing information and tips and some tricks. And also wanted to let you know that the webinar is being recorded, and we're going to be posting a recording on the Canadian Network for Health and Housing of People Experiencing Homelessness, cnh3.ca, and the website you see there. And there you'll also find a mountain of resources that we have put together. So we are very lucky today to be joined by two amazing folks. One is Dr. Monty Ghosh. You see his CV right here. He is an accomplished internist and addiction specialist. He's done a lot of work on the front line of homeless services and is currently working today with Alberta Health Services on the response to COVID-19 in Alberta, I believe, or just in Calgary. We also have, oopsie, went right by Sandra. We also have Sandra Clarkson, who is the Executive Director of the Calgary Drop-In Center, and Monty and Sandra have been working very closely together to protect our neighbors here in Calgary from, our homeless neighbors from experiencing COVID-19. So with that, I am going to stop sharing my screen and pass it over to Sandra and Monty, and I will be back to moderate our question and answer. Sandra and Monty, you want to share your screen? Away you go.
Absolutely. Thanks again, Tim, for having us here, and super excited to talk to you guys about this important issue. I know there's a lot of experts who are participants here. Just saw Wendy Muckle on, and I know she's hugely involved on this front in Ottawa. So yeah, we're talking about COVID mass outbreak management for vulnerable populations. This is just my copyright slide. And these are my disclosures. I have no pertinent disclosures to share with you folks today. And I want to start off by talking about why our population is such a higher risk for COVID mortality. There's several different factors for this. For one, our population is at higher risk for immunocompromisation. So we have a large population that has HIV and hepatitis C as well, and it's disproportionate to the number of clients, to the regular population, I should say. We also have, our clients also have a huge risk for cardiovascular disease. So for example, we know a large portion of our population does smoke. A recent, or not a recent, I should say, it's 2005 study from Toronto demonstrated that the prevalence of smoking was 79% higher amongst people who are experiencing homelessness than the average population group. We also know that a large portion of the population does suffer from hypertension, high cholesterol, and diabetes, also risk factors for cardiovascular disease. But while these three processes are not more prevalent in our population group, they are poorly controlled. And we know this because of poor medication adherence, access to primary care support workers, providers, etc. So for this, we know that they often have poor outcomes and that are higher risk of having coronary artery disease in general, which puts them at a higher risk for mortality secondary to COVID-19. Looking at other comorbidities, pulmonary disease is huge in our population group. So there's a cross-sectional study that was done in San Francisco that demonstrated that 24% of clients had asthma, 19% had chronic bronchitis, and 4% had confirmed chronic obstructive pulmonary disease, which we need to have some certain testing to confirm, such as a pulmonary function test, and not all of them have access to this. So we actually presume the prevalence of this is higher than normal, than these numbers show. In terms of age, we do have an aging population. From recent stats from Toronto, about 70% of our population there experiences homelessness and is above the age of 55. And in terms of Calgary, for example, we have about 11%, and every year this number keeps growing, of course, as you guys already know. So both of these, again, are risk factors for COVID-19 mortality. What are some indirect risk factors, however, include mental health and substance use. So we know from an analysis pulled from various different studies throughout the world, and mental health and substance use are as high as 77.4% in our population group. In Calgary, we did a recent survey back in 2018 regarding this, and we found that 82% of our clients had used alcohol regularly, and almost 90% of them had some sort of substance use concern in the past. So what does this mean? So there's huge implications for this. It means that our population is twice as likely to be hospitalized compared to someone who's stably housed because of COVID-19. They're also 3 to 4 more times likely to require critical care supports, and 2 to 3 times more likely to die than the regular population group. So not only are they at higher risk of having COVID-19, but they're higher risk of mortality. And the reason why they're at higher risk of catching COVID-19 is for the following reasons. It comes down to hygiene. So in terms of hand hygiene, we know this is fairly poor in a population group. There was a cross-sectional study that was done in Boston that found 61% of individuals wash their hands 5 times or more per day. 37% wash their hands 2 to 4 times a day, and 2.6% were able to wash their hands once a day or not at all during the daytime. It's fairly significant. Bathing, 72% reported to bathe daily, 21% bathed 3 to 6 times a week, and 7.2% say they showered 1 to 2 times per week. In terms of laundry, not all clients can do their laundry. 63% say they wash their clothes 1 to 2 times a month. 5% report not being able to wash their clothes at all. All of these risk factors put them at higher risk of acquiring COVID. And so again, combining that with the risk of mortality from COVID, this population group is at high risk for poor outcomes. So when we look at outbreak management, there's 4 key components. You guys might have seen these in other documents out there as well. I know Andrew Bond and his group in Toronto, along with Aaron, have sort of come up with some of these already, and you might have seen them from their talks and conversations. We've seen some documentation from Ottawa that sort of demonstrates the same as well, but these are the 4 main steps. There's prevention and preparedness, screening, isolation, quarantine, and then mass outbreak management. And we'll really try to focus on all of these, but more so on the mass outbreak management plans. With this, I'm going to actually pass it over to Sandra.
Thanks, Monty, and thank you for inviting me to present here with you today. I think it's a great opportunity to share some of our experience that we've had on the ground. The Calgary Drop-In Center is a large homeless shelter. The shelter is 5 stories tall, and prior to this pandemic, we were sleeping on average about 650 people per night in that space. And so as this came about, we've had to change a lot of our practices, protocol, how we do our service delivery. And so happy to share with you some of the things that we've been able to achieve. And as Monty just mentioned, you know, hygiene is a critical component in terms of reducing spread, and is an issue for this population in terms of having access to that hygiene. So one of the first things that we did was we brought in portable hand washing stations and placed them throughout the building, and encouraged people upon entry. We would provide hand sanitizer to everyone that came in the front door, and did that again at meal times, and tried to encourage hand washing with posters, communication, conversations, just really trying to increase that level of hygiene. The physical distancing, as you can imagine, with 650 people in a building, was really, really challenging and seemed really daunting at first. I am happy to say that we have been able to, through decanting and housing, people have been able to reduce the numbers of people in our main building, and are able to now meet that 2-meter distancing that is recommended. In terms of cohorting clients, yeah, you know, the ideal is to have people in groups of less than 20. I know that's not always possible. It's not possible for us in our main building, but we're trying to get as close to that as much as we can. Another change that we did was assigning people to specific bunks and floors, so that we can keep track of where everybody is sleeping. so that should there be a positive case, we know who was in close proximity, and it will help with the contact tracing. And as I'm sure lots of people experience in cities where there's more than one shelter site, migration between sites is an issue, and we're really trying to prevent that by assigning people to specific shelter sites. And if we move on to contingency planning, Monty, another area, although we are a 24/7 operation, not all of our sleeping floors were open during the daytime. We did offer day sleep as well on our 3rd floor, but since all of this has happened, we have had to increase our staffing levels to have all 5 floors open 24/7. And we've assigned people to specific floors and encouraged them to stay on their floor. And, you know, we continue to provide all of the services that we did prior, but we are limiting the number of people in the building and, you know, doing our best to provide overflow sites so that if people do present and are in need of services, that we can make sure that they get the help that they need. Calgary does have an assisted isolation hotel site, and transportation has not always been smooth to that location, but I believe, you know, we continue to work on that to make sure that there is the ability to transfer people who are symptomatic and or positive out of the shelters as quickly as possible and into those isolation sites. We've had to increase our staff levels by over 120 people so far. So prior to all this starting, we had on average about 270 staff. We're now well over 400 at this point. So, and continuing to recruit. We know that we've had a lot of people who have had to go out on self-isolation, and so we need to be able to backfill, as well as we've had to decant other satellite shelter sites, so we had to ramp up staffing for that as well. We also had to suspend all external volunteer opportunities, which had a tremendous impact on our operations. In an average year, the number of volunteer hours contribute the equivalent of 93 full-time staff to the agency. So we have had to be very creative in terms of how we can continue to provide services, particularly around meal times, and have been able to repurpose other support staff, such as, you know, HR, IT, finance, admin, to help with some of those frontline service provisions. And then, of course, considering the need for extra supplies, food, toiletries, PPE was always, and I know is an issue for everybody across the country, making sure that you have adequate PPE. And I think, again, as I said, it can seem really daunting to put all of these pieces in place, but just start with something that you can tackle in the first place and then move on to the next one, and knowing it's never going to be perfect, but just start somewhere and do your best to get as close to the recommended guidelines as possible. In terms of PPE, we really looked at what would our burn rates be based on a number of different scenarios. So if, you know, originally we were only masking if we were working with somebody who was symptomatic, and then it moved on to different scenarios. And so, you know, we projected what our burn rate would be is if all staff had to wear a mask throughout their shift, how often do they have to change it? And then another scenario about do we have to mask all clients at all times, et cetera, and kind of ran through a whole bunch of different projections there in order to determine what our burn rate was. What I can say is that when we presented those numbers, people were quite surprised at the amount of PPE, but we just kept pushing and were able to explain the numbers. I think certainly what I've experienced is that there's not a lot of clear understanding of the needs of the shelter operations. And so advocate as much as you can with your local health authorities to make sure that they understand the complexities and the needs for your PPE, because it's a critical component for you to be able to continue to operate safely. And then overflow sites. The Calgary Drop-In Centre has to date opened 2 overflow satellite shelter sites, one of which can accommodate up to 56 people, another one that can accommodate up to 300. So as you can imagine, the staffing recruitment was pretty intense to make that happen, but we've been doing okay in that area. Quarantine spaces for people who are waiting to be tested. At our main site on our 4th floor, we do have a small area for people where we consider it our observation location as opposed to isolation, because it is a shared bathroom and there's no doors on the rooms. So that is where we put people when they are symptomatic and waiting to be swabbed and transferred to the isolation hotel. And then protective housing for people who are highest at risk. We looked at those people with the number of different underlying medical conditions that Monty had mentioned at the beginning, and made sure that we prioritized them to be moved into one of the other shelters or satellite sites so that they could be better protected. And then, as mentioned earlier, we do have the assisted isolation site for people who are confirmed for COVID-19 in Calgary. So client and visitor registration and surveillance, it sounds much easier than it is. You know, we do of course have our client database, and as you can imagine, having that many people coming in and out of our building every day was quite challenging. On an average day, we could have up to 1,600 unique individuals coming in and out of the building for various services. So we did have to start restricting some of our day services, such as laundry, meals, to only those people that were sheltering at the main building or any of the buildings. It has been really challenging to stay up to date on that, but we're certainly doing our best and checking everybody at the gate to see where their home shelter is, so to speak, and referring them back to those locations wherever possible. And just making sure that we've got a really clear picture of who's in the building and where they are at all times, so that we can help with that contact tracing that is required when there is a positive case. And I'll hand it back over to you, Monty, to talk about some of the work that we've done on the ground recently.
Thanks, Sandra. So one of the things that we try to do with the Drop-In Center, and hopefully we'll do to our other shelter sites as well, is determine the needs of the clients. So when we had our first case at the Drop-In Center, we knew that we needed to determine what the needs of the clients were at the site and how best to serve those needs in the future, in case some of them did come back positive while they were waiting their swab results. So what we did was we did a blitz. We got a group of physicians together. There was about, I think, 7 of us all together, 5 nurses on top of that, and a lot of healthcare workers, health support workers that joined us too, and an addiction counselor too on top of all of that. And we went to the Drop-In Center and we began a blitz of assessments. We used the form that we use for admissions to the ACES site, the Assisted Self-Isolation site that we have in Calgary, to see what the client's needs would be, how they fit with the ACES site, and whether they needed more supports that we could provide at this facility. So we looked at things such as their baseline medical needs, their substance use and mental health concerns, and we looked at their risk of flight. And a lot of this was just sort of a gut sense. It's hard to determine risk of flight when you're talking to a client for 10 minutes. But again, based off of their history, our gut impression of the client, we're able to sort of triage where the clients would potentially go in case an outbreak did occur. We also looked at their medication list to try to make sure that we did have medications available to them if they had to be transported to the ACES/Assisted Self-Isolation site as well. I'm actually going to hand this slide back to Sandra. We're going to do a little back and forth here. Sandra?
Yeah, so discouraging movement between shelter sites and within the shelter site. Again, a lot easier than it sounds, and on the practical side of things. One of the things that's really important here is information sharing amongst shelters. So we've been able to, with the support and help of the Calgary Homeless Foundation, been able to determine who are the shelter users who are whose patterns have been going between different shelters, so that we can try to assign them to a specific location to try to cut down on that migration. Particularly once we were in an outbreak scenario, we knew that we needed to limit access to the building for people who had not been there from a certain period of time where the risk of exposure was higher. So we just used our database and flagged people and referred them to other shelters where possible. As I mentioned, our day programs essentially ceased for people who were not sheltering at the main building. So no laundry, no meal times or other drop-ins or access to our health services for those that weren't sheltering with us. And just really trying to encourage people to shelter in place as much as possible, but not always easy. And over to you, Monty. Sorry.
No worries. So one of the key things we tried to do was we tried to cohort clients. And I should give you guys a bit of context as to why we chose this method and why we created the guidelines. So the guidelines were there for all the shelters across Alberta to use. We gathered a group of shelter providers, including Sandra, as well as our medical officers of health, other healthcare professionals and operations in Alberta Health Services, along with government representation from Alberta Health, as well as our Community Social Services group. And together we came up with this guidance. One of the key things that we had discussed was the practicality of cohorting clients. So this concept comes from taking our large group of clients. So for example, at the drop-in center, we had over 600 clients and sub-cohorting them to groups so they can stay within their groups. These clients can stay within their groups, thereby limiting the exposure they have to COVID-19 from other individuals, but also increasing the capacity to sort of trace contacts should one client become positive for COVID-19. The thought process is that it'd be easier to easier to isolate the entire cohort as a whole, as opposed to the entire facility. So for example, again, isolating 600 individuals during an outbreak would be very difficult to do. But if each of these, if these 600 individuals are grouped into smaller numbers, we could then isolate them much easier. So if we were able to isolate 20 at a time and transfer them over to our assisted self-isolation space, our ACES space, that'd be much easier to do and much easier to handle. So that was sort of the logic behind cohorting clients. And that was the direction that we gave to all of our agencies within the province. Back over to you, Sandra.
So food handling, I know certainly for us, we needed to make some changes here, particularly in terms of the distancing. When this first started and other shelters were not offering any food in the daytime, our number of meals surged. We had over 900 dinners served, for instance, and it was just out of control. It was very chaotic. We were thinking, how on earth are we going to meet this physical distancing guideline? We've got 900 people coming for a meal. And so, again, we stopped serving people that weren't sheltering with us. We've had to reduce the number of chairs and tables in our dining area. We've set up 2 separate dining areas actually on 2 different floors, and are also, now that people have been assigned to specific floors, are having meals delivered to those floors. So doing our best to make sure, particularly at mealtime, that people are well distanced. We'd always had the practice of people would be seated and then meals would be delivered to them, as opposed to lining up to get their meals. So we continue to do that. That's where we relied heavily on volunteers in the past So again, we've had to repurpose a lot of staff to come and help out with meal times. Now that we've been able to get our numbers in the main building down to a reasonable number, last night we had just over 200. And 227 is our cap to meet that 2-meter distancing guideline. It's been a lot easier to accommodate, but certainly a really important piece is making sure that people are distanced and not sharing food and not sharing cutlery, etc., which is, like I say, much easier to do when you've got those smaller cohorts of people. So far, it's worked out really well for us.
So that was the preparedness and preparation piece, right, that we kind of spoke to. And we're going to move on to the screening part now. And so the strategy that we've taken under Alberta Health Services was to do a 2-part screening process. So the first part is done by regular shelter staff. We call it primary screening, in which they ask the symptoms of coughing, fever, sore throat, shortness of breath, and runny nose upon entry into the facility. We've expanded this criteria now as well to include people who have diarrhea, gastrointestinal symptoms, and it's meant to be a quick screen, a quick questionnaire for anyone to ask, anyone who works in the shelter space. They don't have to be healthcare professionals. Additionally, they will ask questions like, have you come in close contact with a probable case of COVID-19? And or have you been told by a public health individual that you have been in close contact of someone who's COVID positive? So if they answer yes to either of those questions, they're taken to a separate space where they're essentially isolated from the rest of the group, and they wait to be screened further by a healthcare professional, a trained healthcare professional. And so the healthcare professional will then come and see the client and do the secondary assessment and putting their symptoms into context of their baseline illness. We know a lot of our population are smokers, for example. We know they have a baseline cough. So how do you contextualize that with the current COVID-19 situation? We know a lot of our clients have fatigue, have muscle aches, etc. Again, how do you sort of resolve that with their current disease state? So these are the questions that we ask, and this is sort of the process that we've taken to screen our clients. Once the client has been screened by the healthcare staff, if they're deemed as requiring further isolation, we try to transfer them over to the assisted self-isolation space. If they're deemed as not being worrisome for having COVID-19, they're allowed admittance into the premises. So the strategy we've taken is a strategy that they've done in other sites and centers across Canada and throughout the United States. It's called case identification, case removal. As soon as you find a case and you identify the case, you remove them from the rest of the group, the rest of the herd, if you may, and you put them in a separate space with added supports. Ideally, these isolation spaces should be external to the shelter space and not internal. As Sandra had mentioned, at the drop-in center, they have a holding space in which these clients can be transported to or left at while they're waiting to be transported off premises. Ideally, we would want private rooms, but this is not always practical for a lot of the shelter spaces that are there in our community. And then ideally, clients who are pending the results should not participate in small group situations. And we want to really adequately triage our clients based on their medical needs and risk of flight and mental health and substance use needs. And this really does help us and determine, I should say, where we need to send our clients to if they do come back COVID positive. As I mentioned earlier, we did a blitz of the DI to see who would fit where and to get a broader sense of what the numbers would be like and to determine whether or not we needed added capacity to handle these clients. And so while these clients are in these isolation spaces, they're provided adequate medical, substance use, and mental health supports, but also some social supports as well. And that social isolation piece is huge in terms of keeping clients engaged with their own isolation. And we try to check in our clients while they are isolated at least twice a day verbally through phone calls or knocks on the door, and more if needed if they are medically unstable or require further supports. This is our triaging tool. It's very much adapted from what's going on in Ontario. we kind of took what they've been doing and tried to modify it for our own needs. We have different levels of medical grade on the left-hand side, as you can see. The higher grade, the higher medical requirements there are for these clients, the more likely they are to go to hospital for their isolation space, as opposed to coming to our assisted self-isolation space, because we don't have the right staffing and the right amount of medical supports to support these clients. On the top x-axis, we have mental health and addiction concerns and flight concerns. And again, the higher they are on that category, the more likely they are to be sent to hospital or to an institution. And that has been posed as a potential option for our clients, as horrible as it sounds, if they are not self-isolating or unwilling and unable. So this is sort of our matrix that we have to help clients. I'll share this later on, or you guys can take the slides afterwards as well. But again, very much adapted from what's going on in Ontario. So in Alberta, the definition of an outbreak means one case. As soon as one case is identified in the shelter site, it is declared as an outbreak within that space. I know this varies from region to region. One of the things that we tried to do was try to make sure that we had a universal consensus on what the declaration of outbreak would look like and what the definition is in terms of the numbers, and also determine the roles and responsibilities beforehand. So who handles an outbreak situation? Is it public health who takes care of it? Is it Alberta Health Services? Is it one of our community agencies that participates? And again, really clearly defining these roles beforehand was beneficial when we actually had an outbreak situation. Sorry, lost my presentation there. Also, in terms of managing an outbreak, we want to make sure that we swab all of our clients and contacts, including staff. And then we would consider a lockdown if needed. Fortunately, we haven't had to go to that situation. A lockdown is where the entire facility shuts down and no one is allowed in and out of the facility except for staff. We kind of imagined the scenario as being kind of like locking down the Princess Island cruise, or the Princess Cruise Line, I should say, that occurred earlier on. Again, you want to keep as many clients in the facility as possible, decanting certain clients if necessary based on their medical complexity and medical needs. The other key thing here is to limit staff to client interaction as much as possible and ensure staff wear the appropriate PPE. So when we do have this outbreak situation, we do another blitz. And one of the reasons why we did our blitz earlier on was sort of to have experience to handle these blitzes during a lockdown situation. When we do our blitzes, we want to isolate symptomatic clients first and foremost. We want to keep them separate for those who are non-symptomatic and do further testing on them, do further supervision of them to make sure they do not deteriorate. We're trying not to permit mingling between these clients as well. Enforce restrictions and isolate client movements, limit access to other facilities, and make sure they're only staying to their assigned floor and space. We preferably want a washroom solely for isolated clients to use and clean and disinfect these areas as frequently as possible, and then continue to provide meal support to the cohort and other essential services as we normally would do. And if separation space cannot be provided, and we can't cohort our clients, we can do a large group setting, but we have to ensure that there's at least 2 meters of spacing between these clients. So a perfect example of this is actually the Expo Center in Edmonton. So in Edmonton, what they've done is they have taken over a large convention space, added cots. Each cot is at least 2 meters away from the other cot, usually more than that, sometimes up to 3 to 4 meters away. And they've tried to make sure that clients stick to their own cot, and they've set up 3 different spaces. One space was for clients who are COVID negative. Another space is for clients who are pending results. And the third space is for those who are COVID positive. Of course, one of the big challenges here is that it's hard to keep clients separated from each other. The Expo Center has done a good job of having support workers come in and try to redirect clients from getting to each other's spaces as much as possible. And for the most part, from what I understand, clients have been fairly compliant with this, although not always. After you do your initial swab, and again, as I mentioned, we swab everyone at the shelter site. What we want to do is we want to do a secondary swab. And we haven't done this quite as yet here in Alberta, and we're still waiting to determine if we have the resources for this. But this is based off of a study that was done in Washington State. Essentially what happened was they had an outbreak of COVID-19 in one of their shelter sites, and they did an initial testing event in which they swabbed everyone. Out of this population, they found that 15 clients were positive, and only one, I believe, was actually symptomatic. What they did then was a week later, they re-swabbed everyone and found that even those who had tested negative first time around, 16 of them, as well as staff, came back positive the second round of swabbing. So, I mean, this goes to show that it might be worthwhile swabbing clients a second time around after they've come back COVID negative, just to ensure that you are able to isolate these clients as well. Again, in Alberta, we haven't come to that consensus as of yet, just because of limited resources, but it's something that we're actively discussing in the background. And so, as I mentioned earlier, should the need arise, we might need to have a whole facility isolation or lockdown. We've done this with a lot of our nursing homes in the province and long-term care facilities, but we have yet to do this with a shelter, fortunately. So we work with the local health authority on this. You want to create strict access to the facility, and then also utilize security to monitor access and movement within the facility, and then identify a space where more sick clients or unwell clients can go, where more supervision can be provided, and then where possible provide independent isolation spaces for these clients, ideally in the form of a hotel unit, but if that's not possible, a cohort isolation space, as I had mentioned the Expo is doing. And then ideally universal masking for all clients and staff. We all know this is difficult to do with our clients. Not all of them want to wear masks. Not all of them know how to wear masks appropriately. And not all of them will continue to wear masks even if you tell them to. So during isolation, whether it's in a mass lockdown situation or whether it's in a hotel room with their assisted self-isolation spaces, there's some key features that you want to have in these facilities. And I know there's lots of experts on this phone call, so I'd love to hear your opinions on this as well. We would definitely want to provide them with substance use management, including harm reduction supports. You want to provide them with detoxification services if need be, as well as potentially treatment services, including pharmacotherapy. Provide relapse prevention, which falls under the pharmacotherapy realm. And then the ultimate goal is to keep clients safe within their quarantine location and make them feel comfortable. Last but not least, recovery. So returning, when we're all done with this outbreak situation, you really want to have clients return back to the facility, reoperate the facility as normal as before. You want to have your same screening procedures in place as before. When we are sending our clients back from the ACES facilities, we usually send them a letter of discharge, letting the receiving facility know that these clients are good, that they've been tested, they've been screened, they've isolated, and they're doing well, and that there's no need for further worry. Of course, we would reconsider isolation again if necessary, if the symptoms begin anew. And with that, we are leaving this a small message here, and I'll open up the floor to discussion and questions. Thank you.
Awesome. Thank you guys very much. So we have a number of questions for you two. So I'll start. I think the first question will be for Sandra. So Sandra, what was your staff client ratio per shift during COVID, and has it changed from pre-COVID?
It has not necessarily changed. It's just been redistributed. Well, no, that's not true. Actually, it's gone lower. Staff to client ratio, depending on the shift and the building, it varies depending on where they're at. I think having the building open, all floors open every day has increased the number of staff, but we have less clients in the building. And what those specific ratios are, I can't tell you offhand because it's really dependent on the floor and the location. But it is definitely something that we did adjust for.
Okay. Another question for you, Sandra. How many COVID positive tests have you had at the drop-in center? And I think this question might have been answered, but what procedures were put in place to test others once there was a positive test?
We have had a total of 5 positive confirmed cases at the main building at the drop-in center. No positive cases at either of our secondary satellite shelter sites. As soon as the first result came in, we were able to isolate people, get them over to the assisted isolation site, as well as test all staff and clients in the main facility. And I'm very happy to say that no further positives came about as a result of all that testing.
Awesome. You know, in thinking about the size of the drop-in center and the scale of the challenge, the fact that you haven't had any other positives and were able to keep an outbreak to 5 feels like a real testament to what your team was able to pull together so quickly.
Yeah, and I think a lot of that is those the preparation pieces and like that increased access to hygiene and limiting interaction. So I think there was probably a fair amount of good luck that came with that as well. But I think you know, we'll take it. That's for sure.
So a question, Sandra, aside from Monty, what support are you getting from, or did you get from Alberta Public Health or Alberta Health Services?
Well, I have to say the support of the medical community has been really phenomenal. We started out by having, at the very beginning, a number of medical professionals who came and volunteered their time to help us with our screening processes, to train our staff on proper use of PPE, how to do the screening. And that was all voluntary actions on behalf of the healthcare community. And then as things progressed, we did get further supports from official supports from Alberta Health Services and a lot of Monty's colleagues. And we're very grateful to see how that community has really rallied to support those that we serve.
Awesome. So what was a question here from Clovis? What was the purpose of the overflow sites and how was it different from isolation?
The purpose of the overflow site was to be able to get our numbers down so that we could meet that 2-meter distancing, both in the daytime and during sleep. You know, as you can imagine, with 650 people in the building, it's really crowded conditions. And I know that's certainly something that we never want to go back to, but to meet the 2-meter distancing for sleep and daytime, our building capacity is 227. So we had to relocate a significant number of people in short order.
Yeah, no kidding.
Oh, sorry. Can I add a bit to that as well? I mean, just to clarify, it's, I guess Sandra mentioned, it's for physical distancing, not for isolation. So that's the key difference there. We had a separate isolation space altogether, but that was more for physical distancing. Sorry.
Yeah, thanks, Monty. So you have a question from Wendy Muckle in Ottawa. Are you testing a second time before people leave isolation or just waiting out the 14 days and then releasing?
We're waiting up to 14 days and then releasing. Unfortunately, we don't have enough swabs right now to do the secondary testing. And it was deemed by our medical officer of health, or chief medical officer of health, that that secondary swab was not required if they were able to complete the 14 days of isolation.
Okay. Question from Sandy. How do you assess risk of flight? Is it just assessed through conversation with the client?
It's a hard one. So it's just assessed through conversation with the client. So it's looking at their medical complexity, their substance use history, talking to their case managers, if they have a case manager, talking to people who know them in the community and how adherent they are to their medications. So it's very much a holistic evaluation and sometimes a gut feeling as to whether or not you think this client will leave or not. And I know that's not the best judgment call, but given the rapidness of the assessment and need to isolate, that's kind of what we've relied upon. And we're trying to kind of, again, collect as much collateral information as we can to determine what the needs of the client are.
For sure. Question from Janet. Can you comment specifically on harm reduction techniques re-opioid use disorder?
Yeah, so this is complex. So right now in Alberta, we do not have a supervised consumption service at these facilities, and we're not to do safe supply in our facilities as well. So we're very much sticking to Suboxone, methadone, slow release oral morphine as our primary supports for our clients. We do have an intravenous opiate agonist treatment program that exists in Calgary, and we have a mobile unit attached to that. So our mobile unit is going out to the facilities to provide the clients who are in isolation with their continued dose of IV hydromorphone. But that's sort of the extent of this. In other jurisdictions, however, and I think Wendy Muckle can kind of speak to some of this as well, they do have a supervised consumption service on site at their facility. At the expo site, for example, while we don't have supervised consumption service, there is a safe space where clients can go to We also know that some other facilities in Vancouver, for example, are providing safe supply in regards to tablet oral agonist treatment. So that's tablet hydromorphone or DILIs, in which the clients can then crush and inject if they need be. But they're doing it in a very supervised sort of way. So just talking to Christy Sutherland, who I admire for her work, they've been doing sort of monitored safe supply. So they provide the client with the tablets, but they monitor the client injecting it. So these are the different techniques that are being used throughout the country. Again, you kind of have to follow your local jurisdiction and what's permitted by your local college of physicians and surgeons as to what can be done, what can't be done.
Okay. A question from Kim. Regarding substance use management, what have you done for people who use tobacco, particularly if someone's not interested in using nicotine replacement therapy?
Yeah, that's a tough one as well. And again, if there's other people on this call who have some answers to this, this is one of the things that we've been struggling with. What we've tried to do is we've tried to do nicotine replacement therapy and provide cigarettes. So what the nicotine replacement therapy does is it provides a baseline amount of nicotine. And then in terms of craving spikes, they're allowed to go outside and smoke to deal with that spike. But again, we're hoping that the nicotine replacement therapy reduces the overall requirements to go outside to use a cigarette. Now, if that's not possible, we are providing them with cigarettes to use. We are limiting the amount of times they can go outside to about 2 cigarettes a day because of staffing restrictions. It's hard for us to take clients out on a regular basis to allow them to smoke. Again, open and welcome to other suggestions. Here, the other thing that we would be willing to do is provide them with treatment for their tobacco use disorder. So whether that's nicotine replacement therapy or using things such as Champex as well, we are trying to provide those services to help clients cope with the cravings for nicotine.
Right. Okay, question from Peter. He says he works in a rooming house that has 32 clients. Every Friday, he runs a food bank that's attended by 12 to 16 clients. He wears gloves, masks, and sanitizes regularly during food bank. These clients also maintain physical distancing. He's wondering if there are any other protective measures he should be looking at.
Sounds like he's doing all the right things.
Yeah, it sounds like he is to me. I mean, again, keeping that physical distancing is important. Serving the clients, which he's doing, sounds reasonable and definitely necessary. Yeah, it sounds like he's doing the right things.
Okay. Question from Linda is that she understands there are some homeless people who don't want to use the drop-in center or other shelters. Is there anyone who is checking on them? Where can they access food?
Yeah, I can answer that question. So we do have an outreach team that's helping provide support for these clients. We actually have several outreach teams. They're all collaborating together. So we have what's called the DOPE team. They're run through Alpha House, which is one of our organizations here in Calgary. And they seek out clients and they do that primary screening. So the DOPE team is made of individuals who are not necessarily medically trained. And they do the primary screening bit with the clients. They inform them about COVID. They educate them about COVID. They provide them with information as to where they can access hand hygiene, for example, and other supports, including healthcare supports. If the client does screen positive from that primary screen, they then contact a secondary assessor. So we have the community paramedics as well as SafeWorks, which is a harm reduction nursing support team, who will then come out and assess the client and then assess whether or not they're appropriate for the assisted self-isolation space. In terms of food being delivered to these clients, we don't have supports for that. There are a few groups that are out there in the community that are providing sandwiches to these clients within our city, but as far as I know, I'm not too sure where they could access those supports. Sandra, do you know?
Well, we do provide bagged lunches for people who are not allowed to access the building. So we do try to provide those supports wherever possible.
Okay. Awesome. And you might have touched on this earlier, a question from Nora about safe supply, but you were saying that are there any, or she's asking, are there any supports in place to increase access of safe supply of drugs, both illicit and legal, in either isolation side or the regular drop-in to discourage movement?
At the regular drop-in, there isn't. At the isolation space, as per the directive, we're not supposed to be giving it. Some of the things that we are doing though to to sort of taper cravings is providing like Dexagen, for example, to deal with methamphetamine cravings, providing psychosocial supports for the clients as best possible. We are doing managed alcohol. We have plans to do managed alcohol. We haven't quite set it up yet here in Calgary, although in Edmonton, I believe that they have started at their expo site. And so those are the sort of the things that we're doing. I think the big question about safe supply comes down to opioids. And that's the part that we're very careful with based off of government direction. That's the contentious part, but almost everything else we're managing reasonably well, whether it's alcohol, using stimulant support, for example, which doesn't have a great basis of evidence, but we're using anyway in this particular setting with the goal of keeping clients isolated. And it's only for the 14-day period that they're staying isolated for. Beyond that time period, we're not extending that outside in the community.
How have you found it educating clients on COVID and the need to isolate? Have you been experiencing resistance from them?
From my personal experience, no, they actually do understand what's going on, I think, for the most part. Many of them are worried about COVID. I've heard a couple stories about people being afraid to go into shelters because of fear of being exposed to COVID. But I think for the most part, on my end, clients have been fairly receptive to the discussion and are more or less aware of what's happening. Sandra, anything to add on your end?
Yeah, I think, just like any one of us, I think there's a significant amount of anxiety in the client population and, unknown and, what comes next. So we try to provide as much information as possible. We have like posters everywhere. We do announcements, over the PA system. We try to have as many face-to-face conversations with people as possible to really educate them on the importance of that hygiene piece. And there's no doubt, the decrease in our numbers, I think, and the nice weather has probably resulted in more people finding alternate arrangements or rough sleeping because of the fear of coming into the main building, because it is currently an outbreak site. So I just think we try to provide as much information that's accessible and understandable for people as we can, and just keep it on repeat.
That's great. Sarah has a question. She says, I work in a shelter that's currently housing about 40 individuals. We recently had to isolate a client, but our facility does not have separate bathrooms or rooms. The client was very reluctant to wear PPE or respect quarantine procedures, and due to behavioral issues would not be accepted into a hotel room. We have no separate isolation sites designated currently for those being tested. Do you have any advice? There's reluctance to send the individuals awaiting testing to hospital.
Yeah, that's a hard one. I mean, what I would suggest is, again, keeping your staff and your other clients as protected as possible. So if this means having a separate space for them, getting them to leave the space and finding an alternative site for them to go to would be very important. This is a tough situation because you're trying to balance the rights of the client versus protecting everyone else. And so I don't think there's any sort of easy solution for this. If the hospital is not an option for you guys, maybe finding another agency or another shelter site that has some isolation space might be an option for them to take on these clients. If there's housing, housing is so key for this clientele. So if it's possible to house them, that would be a really good option. And actually, that's something that we haven't really touched on, is how housing is the ultimate solution for a lot of these issues that we're running into in the shelter sites during the COVID-19 pandemic. But this is a tough one. Sandra, any other options?
No, I think, what we've experienced here in Calgary is if people are non-compliant, then they end up going to the hospital, right? So,
So
I don't know what else to offer.
Yeah, and then we have the institution spaces, which we are trying not to send our clients to. The last thing we want is for them to go into a correctional facility. But again, there is some mandate for that as well.
Sandra, tell us a bit about your housing blitz, your housing strategy that you've just launched at the Drop-In Center.
Well, as Monty said, we know that the ultimate long-term solution here is housing. And so, rather than continuing to move people from shelter site to shelter site, we wanted to really take this opportunity to put a call out to landlords across the city, asking for, rooms or units that are available for rent anywhere between $300 and $900 a month. And we've done a social media campaign, a call out, other media around that. And we've had a really positive response so far. And so it's been great. I think, we have not lost sight of our housing focus through this pandemic. If anything, it's just given us more impetus to really push. And, since the beginning of March, we have housed over 70 people despite all of this. So, we're really holding steadfast to that piece, and hopefully we can continue that trend.
Awesome. Jeanette's wanting a quick clarification on when you use the term blitz. You referred to, what were you referring to? That was testing, correct?
Yeah, so it was a bit of testing and screening and evaluation. So it's kind of all mixed. So we had a testing blitz that was done by public health, in which they came in and they swabbed everyone. But secondary to that, a group of physicians, nurses, and healthcare providers came in and assessed everyone about their medical needs, mental health needs, medication requirements, and management plans for them should they need and require isolation, which included whether they required harm reduction supports or whether they required treatment. What we did find is a lot of our clients did actually want treatment for their substance use disorder. And so we were able to actually get some of that started as well, which was an interesting outcome from this, and which is a welcome outcome as well. So yeah, that was kind of what we did.
So Robbie is a question about some flight clients. So they have 2 flight clients are finding their way into smaller rural towns with the thought that they will find housing. Couch surfing is not as readily available to the host because the host fears infection. No shelter facilities are existing in the smaller towns. The ultimate solution returns the clients to the original city where they feel exposed to COVID and other triggers. Is there any direction or advice available to small towns who are experiencing homelessness and not equipped to handle, and don't have a shelter facility?
Yeah, this is a tough one because we're facing this in Alberta as well. So it depends on how much funding you have. So a lot of these smaller town sites and Indigenous communities do have their own shelter spaces, regardless of how small. They do have shelter spaces, and so they are providing supports for the clients there. For those that don't, such as within Calgary, for example, Airdrie, Okotoks, and Cochrane have a reasonable homeless population. I think 30 to 50 clients in each city, but they don't have their own shelter. We do request that they come into Calgary for supports. It's a tough thing to say, but when there is no support for those clients, it's best to come to a space where they can get those supports. And this is just because of a lack of resources in general that we're suggesting this. If we weren't so, if resource was not a bottleneck in our system, then I think we could potentially provide some other options for these clients. But this is where we stand right now.
Okay. Are there any new protocols you're aware of or available for overdose response?
Yes, there is. So Alberta Health Services has come up with some new protocols. I know they are a bit different than other sites around the country, but I'd be happy to share those later on. I would strongly suggest that you go to your local jurisdiction and find out what the recommendation is of that jurisdiction, because again, it varies from place to place. CRISM is coming out with a set of protocols as well and guidance around overdose management and response. They're doing an environmental scan of the entire country to see what's going on and coming up with a consensus-based document on that piece. So stay tuned for that. I know this has been on Sandra's mind quite a bit since the number of overdoses. Maybe I can let Sandra speak to that a bit more.
Yeah, so we did alter our overdose protocols at the drop-in center. In the past, we would initiate rescue breathing with bag valve mask and CPR. And so we are now only, the frontline staff is now only administering naloxone and not doing chest compressions or rescue breathing. Another thing that we did do though, is we have added LPNs to all of our crews. So they're embedded into every shift so that they're able to provide oxygen as well while we're awaiting EMS support. And thankfully, I'm happy to say that every overdose reversal has been successful so far, despite changing those protocols.
And again, it varies, and it also varies depending on medical expertise. So for example, like I think myself being a physician, I would engage in chest compressions. One of the big things that we've learned from the Heart and Stroke Foundation, for example, is to provide a mask over the client while you initiate that procedure, because it can aerosolize COVID. And then on top of that, wearing an N95 mask as a healthcare provider is crucial to prevent yourself from acquiring COVID should the client wake up. And then we also want to tilt the client to the side in case they cough up when they are going through withdrawal. Again, it's based off of my personal expertise and my willingness to take these on, but it can't be expected of everyone who doesn't have that type of training.
Right. Have you experienced any integration of or expansion of remote or online phone support services for clients that would normally be served face-to-face? And if so, have there been challenges in making such supports accessible for clients who may have fallen off the grid or not have regular access to technology?
Yeah, that has been challenging. So we do in Alberta have had a long-standing support network for clients who have technology to access healthcare supports. So we have a virtual opioid dependency program. Right now, through a rapid access addiction medicine program in Calgary, we're providing province-wide supports for all addiction treatment and concerns. But again, it comes down to, as you just mentioned, supports for clients who don't have phones and technology. For that, I think outreach is the only other piece that we can possibly do, or have them come into clinic. And we are willing to make those provisions, and we do have PPE on standby for that. But that's a very tough group of individuals to go to help support. So at the drop-in center, we needed our blitz. As I mentioned earlier, we were able to assess clients there and then get them onto treatment. We often see if they can actually talk to their pharmacist and use their pharmacist as a catalyst for communication. So we would communicate with the pharmacist, we would communicate with the client, and vice versa, or do phone calls from the pharmacy itself. So when the client shows up to the pharmacy, we would initiate a phone call with the pharmacist then to provide the client with addiction supports. So those are strategies that we've been using. There is a broader document, again, coming out of CRISM, so that's the Canadian Research Institute of Substance Misuse, and that's going to be coming out soon in regards to telemedicine and long-distance support and virtual support for clients who are dealing with the COVID crisis. And in terms of checking in at the isolation space, we're using this technology as well in these spaces too. So those who are isolated, we're trying to do twice daily phone calls, and if necessary, doing walk-ins and knocks and physical evaluations to supplement that.
All right, one last question for you both. Sandra, or it's mostly for Sandra, but did you encounter any issues with recruitment? And how did you overcome the concerns people may have about working with an at-risk population, or did you provide any premium pay?
That's a great question. You know, we did a very big blitz in terms of trying to recruit people. We did social media, took radio, TV ads, calling for people to come forward. And, you know, there was a lot of people that originally came forward, and then, you know, when an offer was made, they declined, particularly after we became an outbreak site. I think one of the things is we make sure to explain, you know, that we've got full PPE and proper use of PPE and appropriate training. And so far it's been okay. But it's, I mean, staffing's a challenge at the best of times, right? Let alone during a pandemic. And so we just continue to cast the net far and wide, and hope that people will continue to come forward as they have so far.
Awesome. Well, that is a wrap for us. I want to just take a minute to thank Monty and Sandra for joining us. That was very, very helpful, very informative, and I know there's a lot of interest from the folks on the line and the folks that are going to watch this webinar as a recording. So thank you all for your work. Thank you for everything you're doing day to day, and to everybody that's on the line and watching. Thank you guys very much for all the work that you're doing. Again, this is a huge task, a major undertaking. And, you know, I've said to some other people that, you know, if given how vulnerable our clients are to COVID-19, the fact that there haven't been just catastrophic loss of life and levels of outbreak comes down to the work that all of you are doing on the front line every day. So I just want to thank you all for that, and please let us know if we can be of any assistance. Thank you all. Take care of yourselves, stay safe, and we will see you all soon.
Thank you.
Thank you.
Thanks, guys.